Hello, it's Nicole Mashburn again. All right, so today we're going to continue with respiration, and we're going to talk about the mechanics of breathing, how you do it, and some respiratory volume, so how much air you breathe in and out. Okay? Alrighty. So, mechanics of breathing, how do you do it? Actually, pulmonary ventilation is two phases. You have to breathe in, which is called inspiration, which is gas flowing into the lungs, and expiration, which is gas leaving the lungs. So breathe in, breathe out. Inspire, expire. Okay? And the way that happens is due to pressure. It's actually a pressure change, and these pressure changes will actually determine whether or not air is going to come in, you're going to inspire, or air is going to exit or expire. Okay? You have to have the right setup of pressures inside the pleural cavity, otherwise you cannot breathe. So the pressure inside the pleural cavity has to be lower than the air pressure, or otherwise the lungs would collapse. Okay, so pressure within the pleural cavity has to be lower than air pressure within the lungs. Otherwise, if there was more pressure in your pleural cavity, it would just force your lungs to collapse. Which is why it's important if you get a pneumothorax and there's actually a hole in your chest cavity, that's going to allow the air pressure to be equal on both sides and your lungs won't work. So you have to have low pressure kind of in the pleural cavity in order for your lungs not to collapse and you can be able to breathe. So if you don't remember what your pleural cavity is, go back and look at that. Okay. So this is what this is going to look like. So atmospheric pressure, okay, has got to be greater. So when you breathe in, that pressure that's going to go into your trachea, into your bronchioles, and out into your lungs is going to be greater than the pressure inside the pleural cavity, which is called the intrapleural pressure. Now, I'm not going to make you remember all these numbers. So to me, memorizing numbers is really not that important. Really, the only numbers I make you memorize have to do with pH. So don't have to remember actual transpulmonary pressures and things like that. Just know the pressure inside the lungs has got to be greater than the pleural cavity. Otherwise, you can't breathe. All right, so how do you breathe? One thing before I kind of show you, talk about it in detail, is I want to kind of give you a visual. Think about if you are going to give someone an injection, okay, and so you have your syringe and you have the plunger all the way to the top, and they're going to pull the plunger down, right? You're going to pull the plunger down in order to bring the medicine into the syringe. So when you pull that plunger down, you're creating a vacuum, right? And that's going to suck, okay? Which is really what happens when you breathe. When you breathe, you have a major muscle called the diaphragm, okay? And when it's relaxed, it's in this kind of a dome-shaped position. When it contracts, it flattens out, okay? So it kind of flattens out. Here you go. It's more domed here. This is when it's relaxed, okay? So now you've been breathing in and it has flattened out. So as that diaphragm flattens out, think about pulling this plunger down. You're creating space inside your thoracic cavity, sucking in. Well, the same thing. So your diaphragm, when it contracts, it flattens out, creates more space inside your thoracic cavity, and that allows the air to be sucked into your lungs. Okay. At the same time, when you're breathing, your rib cage is expanding. So the rib cage is getting bigger, the diaphragm is contracting and going down. That makes your whole cavity bigger, draws in more air. And you know that happens if you just put your hands on your chest. You can feel when you inspire, when you breathe in, your chest gets bigger. And when you expire, breathe out, it gets smaller. So you're just creating a vacuum. So inspiration takes ATP. It's an active process. There has to be contraction occurring. The diaphragm has to contract. I've got your muscles listed here. Your diaphragm contracts. Your external intercostals, which are those muscles between the ribs, they contract. And when they do that, it causes the rib cage to expand and the floor of the thoracic cavity to go down, creating space, increases thoracic volume. That causes the lung to stretch, the interpulmonary pressure increases and draws the air in because air is going to go from high pressure to low pressure. So it's going to be drawn in into your lungs. When you expire or breathe out, that's passive. It doesn't require ATP. It's simply the diaphragm relaxing, those external intercostals relaxing, and everything kind of snapping back into place. So breathe in, relax. Breathe in, relax. This pushes it out. Now, you can use muscles to breathe out. If you're forcefully exhaling, When you're forcefully exhaling, you can use your internal intercostals and your abdominal muscles. So if you want to blow, that requires energy. That's an active process. It's one of the reasons if you're like blowing up balloons and maybe you kind of hurt, your chest hurts afterwards, is because you usually don't use expiration muscles because it's a passive process. But if you're blowing a trumpet or blowing balloons, you may find that you have a little chest soreness because you're using muscles you don't usually use. So you can see just how much space is created during inspiration versus expiration, how big the chest wall and cavity get when it expands and then contracts. There are some physical factors that can limit and change how well you can ventilate, how well you can breathe in. In order to breathe in, these inspiratory muscles have to overcome 3 different factors: airway resistance, alveolar surface tension, and lung compliance. So all those 3 have to be optimized in order for you to have efficient ventilation. So what's resistance? That's something that's increasing the resistance, making it harder to breathe in. So it makes you have to use more effort to bring air in. And you'll see this in things like when someone's having an asthma attack. Typically, airway resistance is when you've constricted or blocked the bronchioles. And so the bronchioles have smooth muscle around them, and they can constrict and contract. Well, if you have a tube, so imagine your tube is this big, and then you clamp it down, makes it hard to breathe, right? So when they constrict, that can make it harder to breathe because it increases the airway resistance. It can be life-threatening. They can have to take something to open up those bronchioles so that they can then breathe again. If you choke, obviously if something's blocking your airway, that would increase resistance, right? That would make it harder to breathe. One of the things they'll give you during an asthma attack would be epinephrine because it will cause those bronchioles to dilate and decrease the airway resistance. The other thing is surface tension. I've talked about it a little bit before. It's basically a surfactant. It's going to line your alveoli, and it's a soap-like lipid protein complex that's made by those type 2 surfactant cells, and it reduces surface tension. So the alveoli are wet, and so if you put, you may have done this before in a biology lab, if you take a slide, you put a drop of water on it and put another slide on top of it, the water kind of holds those 2 slides together. It creates surface tension. And so the alveoli, they can stick together because they're wet. So if they collapse, it's hard for them to open up. So the surfactant reduces that surface tension, prevents them from collapsing and sticking together. You'll see that as a problem in infants, premature infants. They can have respiratory distress because they don't have surfactant and their alveoli stick together. So what you do is those infants is give them surfactant to try to help them have easier breathing. Another thing about alveolar surface tension. If you've ever gotten the wind knocked out of you, maybe you've fallen really hard and maybe gotten hit, maybe had a bicycle accident or something, and you just like, oh, it hurts so bad, and it's hard to get that first breath. You have to really, really try to get that air in. If you've kind of knocked all the air out of your lungs, like with a hard fall, your alveoli will stick together just kind of momentarily until they kind of pop back open. And so you know what it would kind of feel like if you didn't have surfactant. So when you've had the wind knocked out of you, you have that really kind of hard effort to finally start breathing again. That's what it feels like if you don't have surfactant. And there are several disease processes, and people have problems like that with lack of surfactant. Lung compliance, really that's just how elastic your lungs are. It's basically a measure of how much volume your lungs can accommodate. Are they real stretchy? Can they get real big? Are they resilient? Do they go back down to their pre-inspiration size? So basically it's a change in lung volume during expiration and inspiration. If you see actual lung material, it's kind of like bubble gum. It looks a lot like bubble gum, and it's pretty stretchy. Normally your lungs are really stretchy, but if you have things like fibrosis, scar tissue, lack of surfactant, decreased flexibility of the thoracic cage, anything that's kind of has your chest constricted, that's going to make it hard for your lungs to stretch out, and it's going to make it hard for you to breathe. This can be a problem with burn victims, so maybe they have a lot of scar tissue on the outside, and so their skin won't stretch. So if you think about breathing in, your skin has to stretch just as much as your lungs and your chest does, your rib cage. So if you have anything that's kind of decreasing that flexibility of your thoracic cage, it makes it hard to breathe. This is going to be what you'll see with people with that smoke, anything that can cause scar tissue cancers that will cause scar tissue. Scar tissue is not stretchy, so it makes it hard to breathe. So how do we determine if someone has got breathing issues or something going on with respiration? Well, one thing that you do when you want to see their respiratory status is you look at things like respiratory volumes, okay? So you're going to see how much air they're moving. And so they're divided into 4 different volumes. You have tidal volume, your IRV, which is your inspiratory reserve volume, your expiratory reserve volume, and your residual volume. And these are your average numbers. Again, don't have to memorize that, but you can see that males typically have larger volumes, lung capacity, than females do. And this is going to tell you what tidal volume is, the amount, and so you should learn these definitions. The tidal volume is the amount of air inhaled or exhaled in each breath. So just normal breathing. How much air are you moving? Your inspiratory reserve is amount of air that can be forcibly inhaled after a normal inhalation. So just breathe normally. Say take 3 breaths. 1, 2. On the 3rd breath, breathe in more. How much extra could you take in? Okay, that's your inspiratory reserve. Expiratory reserve is how much you can exhale after normal exhalation. So breathe in, breathe out 3 times. On the 3rd one, blow out more. That extra air, expiratory reserve. The residual volume is the amount of air that's left in your lungs after you blow it all out. So there's always going to be air. You cannot blow all the air out of your lungs unless you get hit real hard and you get the wind knocked out of you. There's always going to be a little air left in there so your alveoli don't collapse. So when you look at those volumes, you can do some math and you can turn those into what are called capacities. And so your capacities are called your total lung capacity, vital capacity, inspiratory capacity, and functional residual capacities. Again, males are bigger than females. Don't worry about the actual numbers. I also really am not going to spend a whole lot of time on, you don't have to learn all of these formulas. If you're going to be a respiratory therapist, yeah, you got to learn it. But for us right now, not really. But it is kind of neat to see that you can take these volumes and you can determine some of these capacities. Which is like the maximum amount of air contained in the lungs after the maximum inspiratory effort and all these other things. Again, I'm not going to ask you to define the different capacities. I do want you to be able to define the volumes, okay? But the capacities is really something more that you would do if you're going to be a respiratory therapist. Remember, your lungs have some dead space. There's always going to be volume in your lungs that's not used for respiration. When you breathe in, breathe out, there's always going to be air filling in the trachea and the bronchus that's not used for respiration. Okay, so there's actually some dead air, dead space in the lungs. It's not used for gas exchange. Now, how do we measure these things? We use something called a spirometer. So it's a little breathing machine that measures how much you're breathing in and out. We actually do it in lab if you're in my on-campus class. And so what you're seeing here, I like this one because it shows you those capacities in a visual way so you can kind of figure out what they mean. So your tidal volume, just that normal breathing in, breathing out, just right here and here and here, that's about 500 mLs, okay? If you take that extra breath in, okay, then that's going to be your inspiratory reserve. If you take that extra breath out, that's your expiratory reserve, and then this is that air that's always left in your lungs. Okay, so if you do that fancy math stuff and use your formulas, you can determine your inspiratory capacity, your vital capacity, which is going to be the total of all 3 of these, your functional residual capacity, which is the total of these 2, and your total lung capacity, which is everything added together. I would like you to know what total lung capacity is. Okay, so of all the capacities I should have said that earlier. I do want you to understand what total lung capacity is. It's the biggest breath you can take in plus all of the residual volume that's left. So the maximum volume that your lungs are able to inhale and exhale. So total lung capacity is something I want you to know. and also all the volumes. Okay? All right, so you'll do that to do pulmonary function tests. It's a way to figure out volumes and capacities, and so if someone has asthma, they would do this. If they were having allergies possibly that were causing them to have asthma attacks, or they have emphysema or pneumonia or bronchitis, any kind of breathing disease, they might do a pulmonary function test just to see what's going on. And the reason spirometry is important is it can really tell you, is your problem obstructive or restrictive? So obstructive pulmonary diseases are things that increase airway resistance, okay, like bronchitis. If it's a restrictive disorder, these are things that reduce the total lung capacity because the lungs just aren't as resilient as they need to be. So things like fibrosis, scar tissue, tuberculosis, that's what TB stands for. So doing a spirometry test allows you to determine whether it's obstructive or restrictive. So make sure you understand what an obstructive disease is, like bronchitis, versus a restricted disease like fibrosis or TB. Okay. All right, so we'll talk some more about diseases at the end of respiration. That's all I'm going to talk about today, and I appreciate your time. Thanks again.